I'll go ahead and get started. Thank you, everyone, for joining another pulmonary hypertension grand rounds here on May 12th, as we are all sheltering in place. It's a real pleasure to have a colleague and a good friend, Dr. Steve Kawut, give us a talk on clinical trials and pulmonary hypertension. And as usual, his titles wouldn't be complete without the additive portion of it, from soup to you have to be nuts. So before I introduce Steve a little bit, I'll just ask everyone to please consider muting yourself. Please, that would minimize the audio interference. And if you do have questions, I think Steve wants to make this interactive. So please use a couple of things. So I'll be moderating the discussion a little bit. So please use the raise hand option under your chat function, and I could either interrupt Steve or give you the opportunity to ask your questions. Alternatively, you may want to send a message if you want me to ask that question of Steve, and I'm really more than glad to do so. So Dr. Steve Kawut, he's the director of the Pulmonary Hypertension and Pulmonary Vascular Disease Program and a professor of medicine, biostats, and epidemiology at the Perelman School of Medicine and University of Pennsylvania. Steve did his bachelor's at Harvard and got his MD from Yale School of Medicine, and joined in at UPenn as a resident in internal medicine and stayed on board as a fellow in pulmonary and critical care medicine at UPenn. During his time at UPenn, he also completed a master's in clinical epidemiology, and has really shaped, I think, his career, distinguished him from a lot of other colleagues in pulmonary vascular disease. His faculty position started at Columbia in the Department of Clinical Medicine and Epidemiology. This is where I had the opportunity to meet Steve. Flew out one couple of weeks during the summer, I think, in 2006, and he helped me work through a couple of assays together. I really enjoyed that time, and that's when I first got to know Steve. He later on went back to UPenn and is currently at his alma mater, in the sense that he is the professor of medicine and is really a leader in his division in terms of his work. His clinical activities are in pulmonary hypertension, but not only that, he is also very much involved in clinical care of patients with interstitial lung disease and lung transplantation. He's actually published in that realm as well. So he's not only in pulmonary hypertension. Steve has numerous publications. He's highly cited, a lot of cutting edge work that he's doing. I won't cite his publications, they will speak for themselves. But to tell you that his work and his thought processes really shaped the field, and the FDA has used him as a temporary voting member in their advisory committee in relation to pulmonary hypertension drugs, as well as his position in study sections with the NIH and NHLBI. He's been in the steering committee of multiple clinical trials, including the Artemis trials with Gilead, IPF, and pulmonary hypertension. And the last thing I'll talk about, Steve's contribution to the field has been really the father of the Pulmonary Hypertension Association registry. He is really the one that helped lead and help it shape form. So you might recognize Steve from the first image, but these days he's sabbaticalizing with us here at Stanford. We're really lucky to have you here, Steve. And I felt like I just had to give a little bit, one more pearl of knowledge into the colleagues who are on the call here that don't know you quite as well as I do. Steve is a connoisseur of fine art. He collects sculptures. He's particularly likes sculptures of himself, and you might hear about the Phantom study a little bit. But not only that, Steve really enjoys painting and arts related to paintings that he can hang in his wall. And this is actually a portrait of him which is he's very extremely proud of. Anyways, with all due respect, Steve is a man of multiple talents and a really good friend, and I'm really glad you're here sabbaticalizing, Steve.
Well, thank you very much. Where do you go from there? Thanks a lot, Roham. Thanks to you and the entire program, as well as Division, for being willing to host me over 6 months. It's really fantastic here. I'm having a great time. And as I've told my friends back home, it's better to be locked down in Palo Alto than free in Philadelphia. So I've had a fantastic time here, and I look forward to more time, hopefully in a room together with many of you, rather than just on a Zoom call. So this is meant to be interactive, and so feel free to raise your hand or use the chat function. I think, Roham, you're going to keep on the lookout, and if there's questions, please bring them up, and we can address them as we go along. So I have no personal financial conflicts of interest. My institution has received money for research and for CME courses from the sources listed on this slide. So I'm going to talk about 3 main areas today in clinical trials. And I look forward to a worthwhile discussion over the next hour. We'll first talk about endpoints for clinical trials, treatment heterogeneity, and finally we'll end on the ethics of PAH clinical trials. What characterizes primary and secondary endpoints for clinical trials in any disease? Well, endpoints need to be well-defined, they have to be reproducible, and they have to be achievable. And if your marker has too much variability or can't be performed easily on individuals across multiple centers, not only the US, but the world, this is not going to be a worthwhile endpoint. It, of course, also needs to be clinically or physiologically relevant, or it needs to translate to clinical relevance. And of course, your entire phase 2, phase 3 trial is really predicated on your endpoint in terms of sample size and follow-up requirements. So it's a very important decision. The FDA defines a surrogate endpoint as a lab measurement or physical sign that is used in a therapeutic trial as a substitute for a clinically meaningful endpoint that is a direct measure of how a patient feels, functions, or survives, and is expected to predict the effect of therapy. So I've highlighted here substitute in that a surrogate endpoint in and of itself has really no clinical relevance to a patient. And examples of this are NT-proBNP, a proteomic signature, PVR, cardiac index. I like to think of it as things that your patient would never complain to you about. So in my 20-year career, I've never had a patient tell me that their PVR feels like it's going up or that they feel like their index is low. And so while we think these may be markers that translate to have clinical implications down the line, these have no direct clinical relevance to the patient. How do we validate surrogate endpoints? And what are the properties of surrogate endpoints? Well, again, they need to be reliable. If you can't measure a surrogate endpoint multiple times and get the same answer, it's not going to be useful. Ideally, it should be part of the disease causal pathway and targeted by the treatment. It's not always the case, but it's ideal if it is. You, of course, need a strong association between the surrogate endpoint and the ultimate clinical endpoint, survival or other things. And then most importantly, and this is often forgotten, the effect of the treatment on the surrogate must predict the effect on the clinical outcome. So the surrogate really needs to capture all of the treatment effects or much of the treatment effect on outcome. In fact, it's been said that the effect on the surrogate of the treatment should explain around 50 to 75% of the treatment outcome relationship. But what about hemodynamics? Pulmonary arterial hypertension is really defined by hemodynamic abnormalities, and these are thought by all of us to be really integral to the causal pathway of disease. We know that baseline hemodynamic measures predict survival in PAH in essentially every study which has looked at this. And that hemodynamic improvement with treatment is linked with better outcome. None of these things are surprising. But we wanted to try to formally validate these as surrogates. And so we looked at about 1,268 patients enrolled in randomized clinical trials submitted to the FDA which had right heart cath performed at baseline. So keep in mind, many studies now don't perform right heart cath both at baseline and follow-up. And so there were 4 studies that we used, studies of iloprost, sildenafil, Xitaxtan, and treprostinil. And we hypothesized that treatment-induced changes in hemodynamics would explain much of the treatment effect on clinical worsening, and therefore fulfill the criteria as surrogates. So these are the data that are harmonized. So again, 4 different studies, 656 patients randomized to active treatment, 463 patients randomized to placebo, not surprisingly well balanced in terms of age, sex, race, and BMI. 60% of these patients had idiopathic PAH, and about a quarter had connective tissue disease-related PAH. And you can see the distribution of the studies on the bottom of the table. So I won't show you all of the data, but I'll show you the 2 most important parts. First, and not surprisingly, we found that the change in hemodynamics over time of the trial was very strongly linked to the risk or odds of a clinical event. And so higher right atrial pressure, higher pulmonary vascular resistance were linked to a greater risk of a clinical event, whereas higher cardiac output and higher cardiac index actually were associated with a decreased risk of a clinical event. So hemodynamics were very strong, very strongly associated with the risk of a clinical event. Despite the strength of that relationship, the proportion of the treatment effect of the treatment on clinical worsening was only explained to a very small degree by the change in hemodynamics. So at the very most, pulmonary vascular resistance explained about 12% of the treatment effect on outcome. And so while we think of these measures as very important mediators and surrogates, these data actually show that PVR and other hemodynamics are actually not very good as surrogate endpoints for short-term outcomes in pulmonary hypertension. Remember, we said that in order to be a good surrogate, you would want the marker to explain about 50 to 75% of the treatment effect on outcome. Well, we think invasive hemodynamics are valid, but of course, laying on a cath table is like the least likely physiologic state of all. Central hemodynamics measured supine, don't captured, and of course are not definitively equivalent to the other 23.5 hours of the day when the patient is walking, laughing, crying, eating, sleeping. And so it's a really artificial way of collecting them. But of course, despite the data I've just showed you, change in hemodynamics is strongly associated with a risk of clinical worsening. So these are considered gold standard assessment of cardiopulmonary function, but even hemodynamics are open to several sources of error. Again, using the same cohort that we used for that last analysis, the 4 studies which looked at hemodynamics both at baseline and follow-up. And we actually looked at the measurements themselves. And you can imagine in the absence of bias in these studies, by chance alone, you would expect each recorded baseline and follow-up pulmonary artery systolic pressure to end in digits 0 to 9 approximately 10% of the time. So what do I mean? So here's the baseline PASP. And so here is the last digit of the PASP at baseline, 0 to 9. You would expect, all things being equal, that each one of these would be represented about 10% of the overall cohort. But when you actually look at the actual frequency of the last digit of PASP at baseline, you see that basically a third of patients had last digit of PASP that was either 0 or 5, so a digit preference. When we look at follow-up, we see the exact same phenomenon, whereas we would expect that each of these last digit of the PASP to be represented around 10% of the time. Again, a preference for both 0 or 5. So here in these trials, there's significant digit preference for 0 and 5 in PSP in these RCTs. And this is the potentially avoidable source of error. This is obviously measurement error, right? People like to round to 0 or 5. And you can see that this is obviously introducing some error, not only at baseline, but at follow-up, compounding the error. So even in hemodynamics, which we think are really the gold standard, there can be error in these measurements, human error. What about 6-minute walk distance? Well, we did a very similar analysis looking at patient-level data from 10 randomized clinical trials, a variety of drugs submitted to the FDA, so 2,400 individuals. And if anything, the change in 6-minute walk distance was actually a better surrogate, still not good, but better than hemodynamics, with the change of 6-minute walk distance accounting for about 22% of the treatment effect on clinical worsening. Another group did a study-level meta-analysis of over 3,000 patients, 22 RCTs in pulmonary hypertension, and really came with the same results that, again, change in 6-minute walk distance is not a good surrogate for short-term outcomes in pulmonary hypertension. Well, people have noted that both hemodynamics and 6-minute walk fail as surrogates, but perhaps multi-parameter prediction rules could do better. So while individually these things aren't so great, if we throw them all together in a REVEAL score or a ESC score or European score, then maybe that's the special sauce. And so folks have even proposed using the attainment of low risk status, so a low REVEAL score or many low risk criteria as an endpoint of a trial. So they're thinking about using these constructs and these rules as surrogate endpoints. Well, first, none of these prediction rules have been validated as surrogates. And in the studies that have used this, so COMPASS 3 by Ray Benza, targeting a low-risk profile didn't translate into any better outcome. And so I would just caution that these things may not be valid surrogates. Are these multi-parametric prediction rules better at discriminating patients than the PVR or 6-minute walk distance themselves? We just don't know, but hopefully from the data I've shown you before, just being associated with that outcome doesn't mean that the endpoint is a surrogate. And I showed you data that hemodynamics were strongly associated with outcome, but did terribly as surrogates. And we have the same data for 6-minute walk. So I think we need really dedicated studies to prove that targeting a prognostic rule really results in better quality of life before we start using them as surrogate endpoints. So what about intermediate endpoints? So intermediate endpoints are true clinical endpoints, but are not the ultimate endpoint of disease. Changes in intermediate endpoints are of direct benefit to the patient. So these are measures of how a patient feels or functions. So things like quality of life, activity levels, symptoms, or hospitalization, these are things your patients complain of to you. These are intermediate endpoints and have inherent meaning. There are actually very few studies of patient-reported symptoms in pulmonary hypertension. These are some data from Leanne Matura. She's a nurse at the nursing school at Penn, and she's really been focused on symptom complexes in patients. And not surprisingly, she found that virtually all patients with PH describe shortness of breath, but almost as common is fatigue. You can see also that sleep difficulty is common, and so these are what our patients are feeling and complaining of. And she kind of made these, did a cluster analysis using a fatigue and a sleep index, and really found that she could break out kind of a severe, moderate, and mild symptom clusters. And you can see really there's fatigue, depressive symptoms, chest tightness, lots of dyspnea measures. And so these patients really break out into clusters where some are very symptomatic and some are not very symptomatic. We've never used this kind of approach in our clinical trials, but perhaps we should, and think about some non-traditional interventions like cognitive behavioral therapy or yoga or exercise. Health-related quality of life is defined as a functional effect of an illness and its consequent therapy on a patient as perceived by the patient. And there have been strong associations with health-related quality of life in various cardiopulmonary diseases, and this really hasn't been studied very well in pulmonary hypertension. Steve Matai, collaborator at Hopkins, has actually done most of the work in this area. There's a variety of generic questionnaires to assess quality of life. There are disease-specific ones, including the CAMPHOR and Emphasis 10, and these have been measured in many clinical trials in pulmonary hypertension. But in most trials, therapy doesn't really have a very significant impact on their health-related quality of life. Roham and the group here did a very nice study looking at predictors of quality of life over time. So remember, the Emphasis 10 is a pH-specific quality of life instrument, higher being worse quality of life. He found that, perhaps not surprisingly, higher BMI, worse functional class, higher BNP were linked to worse pH-related quality of life, whereas higher 6-minute walk distance was related to a better quality of life. He also found that more ER visits and more hospitalizations were also linked to worse pH quality of life. There's the real connection here between quality of life and some of the things that we think of as more concrete or physiologic measures in pulmonary hypertension. Leanne Mature did this study looking at physical activity using actigraphy. So this is wearing an actigraph or an activity monitor. She studied 15 women with PH. They wore a hip accelerometer on for 7 days during waking hours. Mean age of 50, mostly white. And she found, not surprisingly, that these patients really had very little moderate to vigorous physical activity. So like less than 3% of their awake time was dedicated to moderate to vigorous physical activity, so very low activity levels. And she actually found that lower energy from the Camphor questionnaire was linked to lower activity counts. Stephen Holliday, who was a pulmonary fellow at Vanderbilt, also looked at this, comparing patients with PH to controls, and again, not surprisingly, found that patients with PH really have very low activity in daily step counts compared to controls. We're actually currently looking at this in Phantom. Phantom is a randomized clinical trial of an aromatase inhibitor, of which Stanford is a participant. And we're doing actigraphy measures at baseline, 3 months, 6 months, and 12 months. And what's really been interesting is to see some of the patterns of people's activity. So this is an individual patient. On the y-axis is the transform vector magnitude. So really this is a summation of the accelerations of that individual. And you can see that their baseline, 3-month, 6-month, and 12-month assessments here are all layered on a figure. And you can see this fairly typical patient gets up in the morning, maybe 7:30, slowly increasing activity in the morning, reaches a peak in the middle of the day, and then gradually comes down at night. And what's nice to see is that it's very stereotypical for the individual. Compare that individual to some other individuals. So here's an early riser. This person's getting up at 4 in the morning, has an increase in activity, which really kind of plateaus and then comes down again. Here's a very late riser. This person isn't up and around till 9 o'clock in the morning, kind of a slow increase to peak activity and then gradually comes down. And then here are some other patients. And again, you can see that it's not just the degree of step counts or the amount of accelerations. There's also patterns here that are very stereotypical for individual patients. And there may be information here. Is there a reason why a patient looks like this, a very small increase in activity, which means really stable over the vast majority of the day before coming back down, compared to a patient who looks like this, who kind of peaks and then drops off.
Hey, Steve?
Yeah, go ahead.
Sorry, could you? What are those dots? Are those dots individual time points, or and then the lines here? Because there seems to be a tremendous amount of variability around those, around the scattering of that data too.
Exactly right. So I don't know if these are 30-second or a minute epochs. So these are individual sampling of activity, and the line is the smoother. So yes, there is certainly a lot of variability. Actually, a fellow, Jasleen Minhas, is actually working on these data and working with you and Ashley's group. This is actually one of my goals of my sabbatical, is to understand more about this kind of activity monitoring. And of course, like anything else, the more you learn about it, the less you realize is known about it. So it's been really interesting. Okay. So the other part that should be obvious is, we've got a lot of different options here in terms of assessment of intermediate endpoints and symptoms. But I want to leave you with the question whether, we really know what patients and their families want from their PH therapy. It should be obvious that their desires and interests vary with age, diagnosis, perspective, and of course, over time, geography, and culture. And to all these people I've kind of described on this slide, a 30-year-old male construction worker with idiopathic disease from Paris, a 70-year-old retired woman with scleroderma from West Philadelphia, 50-year-old from Mountain View versus a 24-year-old man with congenital heart disease living outside Beijing. Do all these individuals really want the same thing? Because keep in mind, the clinical trials of PH drugs that have been performed, including this incredible diversity of patients, have the same primary endpoint for everyone. And it's really unlikely that a 30-year-old male construction worker with idiopathic PH from Paris wants the same thing as the parents of a 16-year-old girl with IPH from the Netherlands. And I think this is an issue with global trials that we need to think about carefully, in that this is not a one-size-fits-all condition. Well, what about treatment heterogeneity? Well, kind of picking up from that last slide, no treatment in any disease is going to have the same effect in every patient. Drug activity may differ by underlying risk of adverse events, or it may differ by type of disease, and this is, again, called treatment heterogeneity. There's a risk modeling approach where you basically use variables to predict the risk of the patient of having an event, and using as a way to stratify. And there's also an effect modeling approach, which basically uses different clinical factors about the patient to look if they interact with treatment. We'll talk about both of these. Even if the drug activity or the relative risk or the hazard ratio doesn't vary, the number needed to treat to prevent one event will be much greater in a low-risk population than a high-risk population. So even with a hazard ratio of 0.5, if the event is really rare, you have to treat a lot more patients to prevent one event than if the risk of an event is common. And therefore, the cost effectiveness and the risk benefit really differs between groups. So here's an analysis using kind of a risk modeling approach. So again, these are our FDA data from various trials listed here on the slide. Patients randomized to placebo are in blue, and those randomized to active therapy are in, I guess, reddish brown. And we first took this entire cohort of about 2,600 individuals and created a logistic regression to predict their risk of clinical worsening. And we used age, sex, race, diagnosis, hemodynamics, and 6-minute walk. So all the usual cast of characters. So we created a logistic regression to predict what is the risk of these individual patients of having an event. We then broke these patients out into deciles. So patients here, the 10% of patients here are at the lowest risk of an ultimate event, and the patients up here are at highest risk. We then looked at the difference between placebo and active drug based on the underlying risk of the patient. And as you can see, the vast majority of activity of the drug, not surprisingly, is in those individuals with a moderate to high risk of an event. And if you look at this lower third, not only were events really rare, of course, by default, they're going to be really rare. They're predicted to have a low risk. But when you look at the effect of placebo versus active drug, there really is no effect. And so you could consider that if you were able to identify this part of the population, you really don't need to enroll these people in your clinical trials. Another way of doing this is using clustering. And this is sometimes called a responder analysis, but it's really looking for treatment heterogeneity. We took that same data set, about 2,500 individuals, and used their continuous variables, hemodynamics, blood pressures, all kinds of things, and threw it into a machine learning algorithm which used unsupervised hierarchical clustering and came up with really three individual groups of patients. So we used the data without telling it how to break these patients up. And on its own, it created 3 clusters. When you looked at the drug activity within those 3 clusters, you see that there's actually a really small number of individuals where there was a profound treatment effect here. So this is placebo, this is active drug. This is a profound reduction in risk of clinical worsening. And again, you could imagine if you were able to perform this kind of analysis and identify a small subset of patients who had a profound response. For example, in your phase 2 study, you could target to just enroll these patients, where you'd need a very small number of patients to see a very large effect. So how can we use this? So again, if you're confident in your predictions from these data, you could actually focus enrollment of those patients most likely to have an event or show an effect. The risk modeling approach was that first example. you could reduce your sample size by a third without affecting power. And this may be a good use of these new prediction rules. Rather than as endpoints, use them as to model treatment heterogeneity so that you could target the high-risk individuals and get the most bang for your buck. Keep in mind that there's nothing special about pulmonary hypertension and treatment heterogeneity. You see this in all human disease. And in general, you see the same effect. You see that in people at a very low risk of having an event, there's less effective drugs than in people at high risk. This really goes along with this concept of a minimally important difference when we're talking about treatment heterogeneity and response. The MID is an estimation of the smallest difference in a measured endpoint that signifies an important rather than trivial change in outcome. Of course, individuals may differ in the impact of the same MID. Recall that other slide comparing the parents of the 16-year-old girl and the 24-year-old construction worker and the 70-year-old woman with scleroderma. All these individuals are going to have different MIDs, and so it's really hard to establish one. Different studies have tried to look at this, and they've come out with estimates of around 35 to 40 meters. This is a nice study from, again, Steve Matai, which looked at this, which again looked at an MID in the 6-minute walk of around 30 to 40 meters, as implying an improvement in clinical outcome. Well, we wanted to look at treatment heterogeneity by diagnosis. And so this is a paper by Rennie Rhee. She's a rheumatologist at Penn. Again, turning to the FDA data from a variety of studies of the drugs shown on the slide. There were about 827 patients with CTD, PAH, mostly with systemic sclerosis, of course, and compared those to 1,900 patients with idiopathic PAH. Not surprisingly, those with CTD, PAH were older, and they had a little more preserved hemodynamics. As we've known from other studies, these patients have better hemodynamics but worse outcomes with a lower 6-minute walk distance. We then looked at a 6-minute walk distance change using what's called kind of a responder curves. So the y-axis are the proportion of patients, and the x-axis is the change in 6-minute walk distance. So for any point on a curve, this is the proportion of patients who had either this change in 6-minute walk or greater, if that makes sense. Here's a line at about 30 meters. So this line denotes individuals who've had a 30-meter improvement or greater in their 6-minute walk distance based on treatment, placebo, and disease type. So in this navy line, these are the idiopathic PAH patients getting active treatment. So about 45% of those patients had a change or an improvement in their 6-minute walk distance of 30 meters or greater. Compare that to those idiopathic PAH patients in green who got placebo, and you can see that they have about, 28%. 28% of them had an improvement of 6-minute walk of 30 meters or greater. Compare that to the CTD patients, which really only 30% of them had a change in their 6-minute walk distance of 30 meters or greater in response to active treatment compared to placebo. I think the important thing to see here is two things. First of all, that idiopathic patients have a much more dramatic response to therapy, and CTD patients have little or no response, and that even in patients assigned to placebo, those patients, many of them have a response. So let's make this more dramatic. And again, this is traditionally what's called a responder analysis. Let's look at super responders. So people who have an 80-meter or more improvement in a clinical trial. So once again, those patients with idiopathic PAH assigned to active treatment, about 20% have an 80-meter or greater response to therapy. And basically all of our other groups, idiopathic patients assigned to placebo, and both groups of CTD PAH patients have basically an 8 to 10% chance of having an 80-meter or larger treatment response. So what we traditionally think of as a major response can be seen even on placebo in RCTs. And so when doing these responder analyses, it's really important to look at the placebo group and to adjust for them. Because if you just look at the active therapy group, you could be deceived. Any questions on this, and is this clear? Okay. So in summary, intermediate endpoints should have intrinsic clinical importance, reflecting patient-centered outcomes. The MID is not clearly defined, but we think it may be around 30 to 40 meters, and that would be useful in trials. When you start to dichotomize 6-minute walk to do these kinds of responder analyses, you actually lose power, and so that's a problem. Not all patients' MID is going to be identical, of course, and I will say that the FDA does not really require this approach for drug approval. More studies have been using it, but the most recent drugs were approved without it. And of course, we need other intermediate endpoints and their parameterization. So finally, in about the last 10 minutes or so, I want to talk about ethics in clinical trials in PH. So we'll first talk about the role of placebo-controlled trials. And I think there's really very little ethical challenges to performing placebo-controlled trials on top of usual clinical care. This actually may increase the research value because in this day and age, you're most likely going to be using any new drug on top of drugs you already have. And so it makes sense to study them that way. The problem, of course, is that the effect estimates of a study drug will be smaller in an already treated population. And of course, this is not specific to pulmonary hypertension. If you do an RCT of a new diabetes drug in patients who are already receiving insulin, you're going to see a smaller effect estimate than if you just did an RCT of insulin itself. So again, it's going to be harder and harder to show a benefit because our patients are going to have more and more treatments. Without background therapy poses a little more of a problem. So it's said that investigators may not assign patients to an intervention known to produce inferior and consequential results that may be placebo only compared to with alternative therapies. So the question is it ethical to have a patient, new PH patient, you've just diagnosed, go on placebo with no other background therapy? And, it really depends on what consequential results means. It really includes permanent declines in health and substantial worsening in symptoms, even if reversible. There are some data that in patients who are put on placebo early on, they don't catch up, even when put on active therapy. But I think that the answer to this question is unknown. The Helsinki Declaration says that patients who receive placebo will not be subject to any additional risk of serious or irreversible harm. And so would 12 or 16 weeks of a patient without therapy fulfill that? I personally would be uncomfortable putting a patient only on placebo. And so I think that studies, even relatively short-term studies in the day and age of standard therapy for PH, it's probably not ethical to do placebo-controlled trials without background therapy. The RCTs in PH have actually, of course, globalized. Again, the Declaration of Helsinki says that medical research involving a disadvantaged or vulnerable population or community is only justified if the research is responsive to the health needs and priorities of this population or community, and if there is a reasonable likelihood that this population or community stands to benefit from the results of the research. That means that the entire population, not just the subjects in the study, must stand to benefit. And I've heard speakers say, well, the patients in this study from China or India were able to get study drug after the, from the sponsor after the clinical trial. The patients in the trial were able to get study drug, and so this was of benefit to the community. But that's not what this means. This means that all patients in China would have the chance and ability to access that drug if Chinese individuals were included in that clinical trial. This recently came up now about 10 years ago, the TRUST trial. Ironically named. This was a randomized clinical trial of IV treprostinil versus placebo. This was a trial that was stopped early by the DSMB for safety concerns. The placebo group in this trial had Hickman's placed and placebo drug delivered. This study was performed in India, And there were lots of issues, including some deaths during catheter placement and lots of infections, and there were charges of coercion, improper oversight, with really an unclear benefit to the larger population, right? It was not clear that after this study was done that any patient in India could have access to IV treprostinil if they needed it for pulmonary hypertension. More recent studies have included large populations from China, for example, Rio Sigwad and the mass attention studies. And so the advantages of the globalization of these trials include innovation, potential access to care, and that patients may get therapy that they would have not ordinarily had. And of course, research in some developing countries may be lower in costs than research in more developed countries. But as I've pointed out, there's lots of ethical challenges here, possibly lower standards for research protection and standard care, potential exploitation. You're using a research population from a country which most likely will not have the chance to benefit from that, from the discoveries from that trial, and that's unethical. You know, in order for the ethical enrollment of a patient population, that population needs to stand to see some of the benefit of the development of that drug, and that would be unlikely to be the case in some of these countries. In addition, you have more patients without background treatment, but again, is it ethical to enroll patients without any other therapy in a placebo-controlled trial? And finally, I want to finish in the last 5 minutes about conflict of interest. So the relationships between physicians and nurses and researchers and the industry and companies are widespread, and these have obviously produced very important benefits for science and patients. But we should remember what the goals are of different individuals. So goals of clinicians are to improve health by providing care for patients, and that is their only goal. The goals of researchers are to conduct valid investigations and to contribute to science and knowledge. And the goals of for-profit companies and pharmaceutical companies are to distribute products that improve health and also ensure a financial return to shareholders. That's just the nature of the beast. There, of course, are additional goals of individuals, and they include prominence, financial stability and profit, promotion and reputation, and these are just realities. Keep in mind that the definition of a conflict of interest is a set of circumstances that creates a risk that professional judgment or actions regarding a primary interest will be unduly influenced by a secondary interest. Conflict of interest is not an action. It's not something you do or don't do. It's a condition. It's a set of circumstances. And I think most don't understand that. Well, what are the primary interests in what we do? Well, research integrity and dissemination, welfare of patients, and quality medical education. But we all have secondary interests. Financial gain, personal advancement, recognition of achievement and prominence, favors to friends, and bad feelings towards our enemies. And these are all part of being human. And if anyone doesn't have these, you can raise your hand and we will applaud you. I certainly do. In terms of clinical trials, there's other layers here. So obviously, participation in clinical trials leads to financial incentives. There's support for travel for research meetings. You can get to sit on advisory boards, give lectures, and get honoraria. If you enroll and are successful in a clinical trial, you can sit on a steering committee, and that's often based on patient recruitment. And of course, you get small gifts and meals, which we don't think causes a conflict of interest, but actually multiple studies have shown that they do. There's obviously also personal and professional incentives, again, lecturing, steering committees, patient recruitment, authorship on papers. So these are not financial incentives, these are professional incentives. Well, what's the harm? This all seems pretty innocent. Investigators in industry-sponsored research express extreme confidence in the capacity to remain impervious to influence, and study after study shows that they're absolutely wrong, that they are influenced. There's multiple lines of evidence and published instances of favorite result bias in industry-sponsored trials. We all know that many negative trials are not published at all, which really compromises the ethics of having done the trial. There's well-known gift-related effects on research and clinical activity, even small gifts, and statements from industry employees saying that this is a known phenomenon. Where does this come up for a clinician or an investigator in a PH clinical trial? So, lots of folks on the call fill both of these roles. I do as well. So I'm an investigator. I want to advance science. I want to advance my career. I need to maintain my funding. And I'm interested in financial incentives. That's a reality. As a clinician, I want to provide the best care to my patients and avoid risks and burdens for patients. So let's say as an investigator, your subject in a trial has significant side effects. As an investigator, your impulse is to advance the science and try to maintain the quality of the research. And so you might treat the side effects and try to maintain the patient and the subject on that study drug. On the other hand, if you're the patient's doctor, research just poses burden. There's really no hope for clinical benefit. And so a subject in a trial has significant side effects. As the patient's doctor, you tell them to get off the study drug, get out of the study. And we're often faced with this dichotomy, and it's a challenge. How do we solve these clinician-investigator conflicts? Well, one proposition is to separate clinicians and investigators. And of course, this is unrealistic. It's unrealistic because it's a rare disease. And of course, the people who have special expertise in treating these patients are the ones doing the studies. And I think maybe the next best step is to recognize this intrinsic tension, that as the patient's clinician and as an investigator, we kind of are working against each other here. I think it's really important to avoid denial and self-delusion of potential impact. When I do talks like this, and this comes up, investigators always say, well, this doesn't affect me, but of course it does. It affects all of us. And I think the best way to deal with this is to strive to manage it appropriately and to recognize that, the physician or nurse investigator who says he or she can serve both investigator roles and clinician roles optimally is just fooling themselves. It's not a reality. The other way to cope with conflict of interest is to disclose. So for money, that becomes easy. It's very easy to write down how much money you've gotten from these companies. It's obviously much harder to disclose personal feelings, your self-interest in self-promotion, your interest in professional success. I'm not going to write down that my conflict is, I want this paper to be accepted so I get promoted. And of course, these disclosures are probably more effective in influencing the behavior of the disclosure than in affecting the individual to whom the disclosure is made. The problem here is that there's moral licensing. Because you're able to disclose things, that doesn't do away with a conflict, right? This is a condition. And the rationalization that disclosing allows us to dispense with the obligation of dealing with a conflict, I think is faulty. I've heard from multiple people the following quote: I take money from all the companies, therefore I have no conflict of interest. So that's absolutely not true. I think in some ways the money is the least of the problems. Most of my conflict of interest are unrelated to financial relationships. They're related to professional advancement, for me wanting to get the paper published. And these conflicts of interest exist in basic science as well as in clinical research. Distance is another way to cope with this. Separate the funds from the individuals in the research. And this is really difficult for large industry-funded trials, which are really necessary to establish new therapies. In addition, many clinical practice guidelines are based on weak evidence and could be prone to conflict of interest. I was on this most recent update of the CHEST guidelines. We used a grade methodology, which was very strict. Those with possible conflict of interest were not allowed to vote on recommendations. And I think for these kinds of guidelines, we need to really work towards maximizing participation of those without significant conflict of interest. Finally, prohibition. So eliminate all industry funding from research grant and other activities. As I've said before, this doesn't solve the other issues of other kinds of conflicts of interest and really is unrealistic in that we need large industry and academic collaborations for proprietary therapies. So I think we really need to consider relationships which will constitute conflicts of interest and how we manage them. So last slide. So hopefully I've convinced you that novel endpoints need to be developed, both surrogate and intermediate. Treatment heterogeneity is implicit to therapy in pulmonary hypertension, and we should, as opposed to kind of looking at it on the back end, maybe plan for it and even use it to our advantage. And the ethical design and implementation of RCTs is really critical to fulfill our obligation to our patients who are going into these human experiments that they think, are there to move the field forward. So making our obligation that we do this in an ethical fashion. Thanks for your attention and happy to answer questions.
Hey, Steve, great presentation as always. Got a question. I get often asked to talk about, what I think should be the next step in terms of designing clinical trials. And of course, a lot of people are still thinking of Gryphon and Bayesian as sort of like what should be the gold standard moving forward. But obviously we know that there's a lot of issues with that. So now my feeling is that we're going back to, okay, well, maybe that 12-week 6-minute walk was not as bad. Maybe thinking about maybe 6 months and combination of imaging with 6-minute echo. So where do you think right now the field should be going? I mean, I understand the limitations you put to, and you made a case that they're there. We just need to acknowledge them. So what does the future for clinical trial design is now looking like?
Yeah, that's another hour's talk. I think, maybe let's focus on endpoints. I think it would be really important to try to validate some novel surrogates. So clearly hemodynamics and 6-minute walk are not good surrogates. Cardiac MRI may be better. So for example, including cardiac MRI in your trial, not necessarily as a primary endpoint, but as a secondary endpoint, and trying to use your trial to validate that against long-term outcome. In addition, I think we really need to focus on what our patients are complaining about. What bothers them? Again, this feels and functions domains. Actigraphy we're using in Phantom, is that a novel measure of how active a patient is? So, getting beyond the 6-minute walk in terms of other metrics which may really measure how a patient is functioning. Obviously, hospitalization, death are going to always be in there. But in this day and age, the fatigue and the dyspnea, bother our patients as much as anything else. And so can we try to target those things?
So Steve, I got a couple of related questions. So yeah, thanks for a great talk as always. So when we think about future trials, you really nicely pointed out that it's not those low risk patients or stable patients that drive the treatment effect. But the reality is, and as you've seen from our database, the large majority of patients that we're seeing now appear to have that impression of low risk, whether it's the therapies or just the better care that we're giving to patients, whatever the advancement. But the reality of it is probably 60 or 70% of the population, the general population, is literally a low risk population. So I guess my question is twofold. One is, how do we see trials going forward that that could show effectiveness? And then the last thing is, I think the second thing is that you may have mentioned, is the generalizability of those studies. So if studies now are using enrichment strategies for more ill patients and they get an approval, well, then I can't use drug XYZ on my patients who are low risk, or at least that's not the label, but people will do it. So could you speak a little bit to that?
Yeah, no, these are great points. I think for the first thing, people are talking about enrichment, right? These they call it responder analyses, but they really mean enrichment, trying to target patients with the biggest effect. And you're right. I mean, one of the problems with that is that you could end up with a label for that very small percentage of patients. And what I would propose is maybe that's a design to be used at phase 2, right? When you need to enroll 50, 60, or 70 patients to really target those where you really think you're going to have the big effect, to save yourself some power. And then in your phase 3, broaden it out, because you're going to want to do that for your label. So maybe that's the strategy. You bring up a good point. Would anybody feel comfortable not treating that 30% of people who seem low risk? No. I think I would not feel good about not treating those patients. And so I think, we can target the high-risk people in initial studies, clinical trials, and even think about enriching our phase 3 studies. But if you want to use therapy in a broader swath of the population, you're going to need to include them, as you say. Hopefully that.
I don't want to. Yeah, that answers it. I don't want to, take all the questions here. Please, people. Anyone else have other questions? If not, then I also have another question. I got many questions for you, Steve. Meaning of life, everything.
Yeah.
Okay.
I hear. Go ahead.
Go ahead.
Oh, please.
So I'll ask another question, maybe a not so tough one. So I think you bring out a really interesting point that just because we design a primary endpoint for a clinical trial, that primary endpoint may not be as meaningful for different populations of patients. So I don't think this is an adaptive thing, but is there openness to having patient-specific co-primary endpoints? So if I know that the farmer is on the farm and all he cares about is fatigue at the end of the day, and I know that I got the techie guy here who wants to measure his PVR by his Apple Google Watch, is it possible to consider a clinical trial? And I know it is, but the power is a problem. Co-primaries, or not even a co-primary, but a patient-relevant primary endpoint. Does that make any sense? Like a personalized primary endpoint for a clinical trial?
It's a very interesting question. I've never seen a trial like that. But as I was kind of preparing this talk, I was thinking about, all right, well, it's great to raise this issue, but what's the solution? You could imagine having different endpoints, or at least different secondary endpoints for different populations. But it raises a fascinating issue that I haven't thought much about. Is how would you design a trial to kind of tailor? I just say it's kind of personalized. It's like personalized endpoints rather than personalized therapy in terms of what's meaningful for the patients. I guess I'm trying to play the role of gadfly, which is to say the trials we have now uses the exact same endpoint for all those patients I put up there, and that it shows the fallibility of these large trials. The other thing you could do is you could weight your endpoints differently. And so function may be different for a 70-year-old woman with scleroderma. Function versus survival may have different weighting compared to a 22-year-old. And so I think maybe we need to, I have a person doing this, ask your patients, valuable to you? What do you want out of therapy? And we're actually doing that in a project, which has some answers.
That's cool. I want to voice a question from obviously our colleagues in the pediatric realm. Rachel asks, how do we find endpoints for children when we're dealing not only with different levels of disease severity, but also different ages, developmental stages, et cetera? We're not talking about adults with different stages of development. We're talking about children.
Yeah, no, and so I threw in the 16-year-old there for Rachel for your benefit. So this is hard to think about. One approach might be quality of life measures, and obviously in pediatrics there's a PEDS-QL with different modules. There's a cardiology module that's specific for heart disease in children. We could think about designing a PEDS-specific module. And of course, those kinds of quality of life measures could be done across the lifespan. The other thing that's really interesting to me is actigraphy. So actigraphy has been used a lot in children, much more in children than in adults. And so, putting a little activity monitor on even a baby who crawls around, you could get a readout of how active the child is. Certainly for a young child, toddler, or, adolescent, they could also be informative. And that's a methodology that, again, you could use across the lifespan. So you could use it in a 60-year-old and use it in a 12-year-old. So activity monitoring may be another approach there. But no, it's challenging in children when there are so many stages of development that you need to account for. And of course, parents as well, with younger children, having parents weigh in on how active, how healthy, how well their child is feeling.
Other questions? Okay, so we have another question from Drew. Can you comment on the current landscape of pulmonary hypertension randomized clinical trials through the lens of the bullet points made in your summary? Good or bad? Are there RCTs out there that currently do a better job in designing and addressing those bullet points and novel endpoints than not? I think Drew wants to get specific.
Yeah, no, it's good. I was going to try to go back to my.
Let's see, phantom.
Yeah, so
some lettuce.
So different endpoints. So again, we're performing a 7-center clinical trial, NHLBI funded. We're using 6-minute walk distance as 6 months as the primary endpoint, really as an intermediate endpoint rather than as a surrogate. But again, we're including actigraphy as a possible novel endpoint. I'm trying to think, and then we're using quality of life questionnaires as well. In terms of treatment heterogeneity, this is a phase 2 study. It's not targeting a high-risk population, but certainly that's something that could be done for upcoming trials. And then in terms of ethical design, we've gotten actually patient input on our trial design, and we're obviously studying treated patients. And so kind of in the trials that we're involved in, we are addressing these points. And I think, different trials probably address them to different degrees, but these are probably things that we want to think about as we're designing new trials.
Should a patient be on the steering committee at any of these trials going forward? Should we mandate that a patient be a steering committee member?
That's a great point. So, Phantom, we have a patient advisory board. A very quick story. We gave them the consent to review and tell us, what they thought about it. So this is before we were pushing ahead. And so the physician came back to us, read the consent, and still could not tell if cath was required or not. And so she said, I read the consent. Is cath required in this, as part of this study? And that was really telling that here, even as a physician who, given the consent form, couldn't tell whether there was a cath required or not for the study, which is obviously really important for patients. In response to that, what we've done is we have a face sheet on the consent, which literally has like 4 points. Number 1, no cath required for the study. Number 2, anastrozole is a drug. Number 3, it's a 1-year study. Number 4, just needs echoes and labs. And literally that is the face sheet on the consent to really drive home specific points. So I think patient involvement in these studies would be a huge advantage. Looks like Juliana has a question for me. How open is the FDA in accepting alternative endpoints? Certainly when you ask them, they are very much open. The problem comes to kind of risk aversity in being, when you're putting $100 or $200 million down for your phase 2 study and you're a company with few therapies, I think it becomes hard sometimes because of the investment to branch out and think in novel ways. So the FDA will accept novel endpoints. They're very open to it. But a lot goes into that. And again, if you had to put your $200 million down, are you going to use an experimental endpoint, something that's novel, or something that's tried and true? Now, I think the way around that is you could still target your 6-minute walk, but include some novel endpoints as secondary endpoints to help drive the field forward. That's a good question.
This might be a naive comment, but the FDA is a regulatory body, right? That we don't have to design studies that the FDA completely agrees with if we think they answer scientific questions.
No, that's true. If you're trying to get labeling and approval for a drug, it does, help to be in cooperation with them and to get their thoughts. But they've expressed their willingness to look at novel endpoints. But I think, before we start using novel endpoints, we need the data to support them. And I'm not sure we have that yet.
So can I think we're 8 minutes past the hour. I think this is really great. We should, if there are other questions, please voice them or email them directly to Steve. I wanted to, if there aren't more questions, I wanted to end the session with back to your ethics. The issue of conflict of interest isn't just an issue of conducting clinical trials. There is a tremendous problem with conflict of interest in peer review, isn't there? And can you speak a little bit more about how we address this issue, this inherent multifaceted conflict of interest in peer review? Should we mandate in the future that peer review process is conducted in an open manner?
Yeah, so it's a great question. Again, the topic of another hour talk. There's conflict of interest in peer review if you're reviewing a competitor's science. There's also conflict of interest in terms of journals. There are journals that want to improve their impact factor. And so it behooves them to avoid studies which may be really important, but which may not be cited and may not get their impact factor increased. And they may look more fondly on studies which will be highly cited, maybe more common diseases, and will improve their impact factor. So again, that's a condition where the primary interest is, accepting the best science for publication. The secondary interest is impact factor of the journal. Even financially, a journal can't sell reprints for a study it doesn't accept. And if a journal accepts a very large clinical trial in a very common disease, that's maybe a lot of reprints ordered by the sponsor, and that's income for the journal. So even amongst journals themselves, not only in the review process, but also in the editorial process, the conflict of interest is also a real phenomenon.
Great, Steve. Well, thank you very much as always. Enlightening and, as expected, a great talk. I'm sure everyone else is looking forward to many more of these talks by you. So you might have a disproportionately high number of requests for these talks. but I'm sure I speak for everyone that we're very excited that you're here, even though it's probably very difficult times, especially in a environment that's not familiar to you, Liz and Ava. We're really lucky to have you here. So thanks for sticking it out.
Thank you again very much. And again, thanks to everybody for having me and hosting me.